The doctor told me that, look, you have hepatitis B, so you cannot go overseas. No one at all from my village had that opportunity to go overseas for study. And for sure, my parents would not be able to afford any of that. So having a scholarship to study overseas is actually a really big deal for someone from a village in the north of Vietnam. And I was lucky enough to secure a scholarship to study in Europe. And as a part of the paperwork, I have to go through a health check. And hepatitis B test is among the health check. So when I came to get the result, the doctor told me that, look, you have hepatitis B, so you cannot go overseas. And then I had to reject the scholarship just because he told me so. I don't know why, by that time, I didn't challenge him or explore more, whether what he said was correct. But look, as a first year university student and you had no experience in life, and then you tend to trust everyone that deem to be more superior than you, like the doctor in the hospital.
In the time it takes to watch this 30-second video, someone will lose their life to hepatitis. It could be your parent, your partner, your child. It could be you. But it doesn't have to be this way. There is a cure for hepatitis C, a vaccine and effective treatment for hepatitis B. We have the power to eliminate hepatitis and save 1.1 million lives each year. It's time to act. Hepatitis can't wait.
Hoy es un día muy esperado para todos los integrantes de la Asociación Buena Vida, porque celebramos la cura de varios pacientes de hepatitis C. Nosotros en nuestro grupo decimos que vivir con el virus de hepatitis C es sentir que uno tiene una bomba de tiempo dentro de uno y que no sabe cuándo va a explotar. La cura significa desactivar esa bomba. Por eso estamos todos juntos hoy para festejarlo, entregar las remeras con la inscripción de hepatitis C curado, y ese es el momento cúlmine de nuestra labor como voluntarios de la Asociación Buena Vida.
Soy Raúl y estoy curado.
Soy Majo, estoy curada.
Soy González Julio y estoy curado.
Hola, soy Susana y estoy curada.
Soy José Luis y estoy curado.
Soy Graciela y estoy curada.
Soy Adrián y estoy curado.
Soy Andrés y estoy curado.
Hola, soy Miguel y estoy curado.
Hola, soy Gabriel y estoy curado.
Soy Carlos y estoy curado.
Soy Nelly y estoy curada.
Soy Claudio, estoy curado.
Soy Rubén y estoy curado.
Hi everyone, thank you so much for your patience and thanks for being part of this. We thank the panels for the other session. So we'd like to share a video from one of our members, that is the World Hepatitis Alliance, who is in Ukraine. They are doing amazing work delivering hepatitis services and meeting other urgent needs of their community during crisis. So I want you to sit back and enjoy and learn from the video. Thank you.
My name is Andriy Chernyshev, and I currently live in Kyiv, Ukraine, and I represent the national LGBT organization Alliance Global, which has been working for almost 20 years to ensure a decent standard of living, health and human rights for LGBT communities, people living with HIV, viral hepatitis, and other key populations in Ukraine. On 24th February this year, a great tragedy took place. Large-scale hostilities began in Ukraine, first by the Russian attack, which has been going on since 2014. And this led to radical changes in the lives of all Ukrainians. The enemy focused its efforts primarily on the destruction of civilian infrastructure, including the medical sector. According to the Ministry of Health of Ukraine, more than 600 healthcare facilities have been completely or partially destroyed since 24th February, more than 100 of which are not subject to restoration. At least several dozen health workers were killed, and the usual supply chains for medicines were disrupted. What we see now, as of 1st of May, due to Russia's war against Ukraine and migration processes in the middle of the country, many patients have lost the opportunity to start or continue treatment for viral hepatitis. According to the Public Health Center of the Ministry of Health of Ukraine, today there are almost 6,500 courses of viral hepatitis treatment available in the regions at the expense of the state budget. In particular, during April, early May 2022, 3,223 full 3 months courses of HCV treatment, together with the drug with the active ingredient declotesvir, were completed and delivered to the regions. Unfortunately, it was not possible to organize any humanitarian corridor so that the Ukrainian side could deliver drugs from HBV and HCV and other vital medicines to healthcare facilities that are under occupation of where there is active hostilities. This is Kherson, Lugansk, partly Kharkiv and Zaporizhia regions. In the new difficult conditions of war, all possible channels of communication and exchange of medical information between doctors and patients should be used in compliance with their rights, such as advising patients online on telemedicine, informing displaced patients about the possibility of receiving services in new living conditions. Much attention of society and international organizations in Ukraine should now be paid to maintaining the continuity of key medical services, including prevention, diagnosis, and treatment of socially dangerous diseases such as viral hepatitis, HIV, tuberculosis, in particular for key groups such as drug users, LGBT plus community, sex workers, internally displaced persons affected by the war. Our citizens must be provided with drugs against these diseases and test systems for the diagnosis and rapid testing for viral hepatitis in full and in the long term. And Ukrainian NGOs need your support and help more than ever. Together, international organizations, WHO, patient and community-based NGOs, we must prevent the spread of the epidemic and increase the number of new cases of viral hepatitis and other socially dangerous infections in Ukraine.
Good afternoon, colleagues. My name is Andy Seal. I work in the Office of the Director of Global HIV, Hepatitis and STI programs, and I will be one of your co-moderators for this next session. I'm hoping that we can get Margaret Hellard, who is working with me to moderate this session. There she is, fantastic. Margaret, always good to see you. I'm sure that the connection is working well. Let's see if we can get the sound working.
Shall I start to speak, Andy?
Perfect. We hear you now. That's great, Margaret. Fantastic.
I'm not sure that there's not a delay, so we'll see how we go.
It sounds as though we might have a second delay, so we'll just be aware of that. It's a long way for your connection to travel, so great to see you.
So Andy, my understanding is I'm meant to kick off this session and welcome everybody. So first, shall I start? Shall we start?
Please go ahead. Thanks, Margaret.
Okay. Well, it's my absolute pleasure to be co-sharing this session with Andy Sill, who many of you will know, who's a senior advisor in the WHO Global HIV, Hepatitis and STI program at WHO, where we are going to be discussing new momentum and high impact through the new WHO Global Health Sector Strategies. We've just heard a fabulous introduction and some really fantastic speakers, and also the video from our speaker from Ukraine, highlighting the importance of what we can achieve if we will work together to eliminate hepatitis B and hepatitis C globally. And so I think this session was going to provide us with some really fabulous insights into that. We have a really interesting group of panel members who will all have a go at speaking, so I'll introduce them as they do so. But first, our first speaker, I think, is to hand over to Andy to introduce. So over to you, Andy.
Thank you so much, Margaret. And it's great to be co-facilitating this session. For those of you who are not aware, Margaret is co-chair of our Strategic Technical and Advisory Committee on HIV, hepatitis and STIs, and has really been a champion for this work through that role, not only in the current format of the advisory committee, but also in past iterations of that committee. So our first speaker for this session will be Dr. Renmin Gui, Assistant Director General for Universal Health Coverage, Communicable and Non-Communicable Diseases. Ren is well known to all of you, I'm sure. He's a great champion for viral hepatitis. He represents WHO on a number of boards that have considerable influence, including UNITAID. We've heard from UNITAID already today, UNAIDS and the Global Fund. So Ren, over to you. Thank you.
Thank you very much, Andy and Margaret. Dear colleagues and friends, good morning, good afternoon, and good evening. I would like to welcome you to this flagship WHO session at the third World Hepatitis Summit, with the themes achieving the elimination of viral hepatitis within the evolving health systems. This third summit builds on the first ever event in Glasgow in 2015, and the second in São Paulo in 2017, and now in hybrid event held both online and in person here in Geneva. We are so pleased to be able to welcome you, especially in person, to WHO campus for this very important event. Today we'll be discussing the new momentums, the high impact gained through the new WHO's global health sector strategies. These sessions of discussion is meant to help us jumpstart the country level's adoptions and implementation of this new global health sector strategies within the needs for people-centered care and integration. The summit is convened very timely. Just over 1 week ago, the WHO Global Health Sector Strategy on HIV, viral hepatitis, and sexually transmitted infection 2022 to 2030 were adopted and approved with a mandate at the World Health Sub-Assembly, which gave us a strong mandate to work on the hepatitis for the next 8 years. This new hepatitis strategy built on the achievements and lessons learned under the 2016 and 2021 global health sector strategies, considers in epidemiological, technological, and sectoral shift of recent years, and foster learning across the disease areas and creates opportunities to leverage innovations and new knowledge of effective response to viral hepatitis, as well as HIV and sexually transmitted infections under the primary healthcare approach. The strategies has been developed based on the science and evidence with broad and intensive consultation. Now is our time to support the member states to implement these strategies within their own social and cultural context. The strategy recommends shared and disease-specific country actions, supported by actions by WHO and partners, and if implemented, has the potential to accelerate the momentum of viral hepatitis response and to meet ambitious hepatitis elimination target of reducing hepatitis incidence by 90% and the mortalities by 65% by the year of 2030. To achieve this target, WHO Secretariat launched interim guidance for the country's validation of viral hepatitis elimination just over 1 year ago. And since that time, we have several brief countries pilot these criteria to access the feasibilities and accessibilities of the target and the process. We are so excited to hear about the progress made, which will be shared during this session. We also learn about new guidance on the hepatitis C service delivery and pediatric hepatitis C treatment. And we will all learn. We must learn from COVID-19 innovations and countries-led pilot to improve our joint response, to improve access to hepatitis testing, treatment, and care, while striving to reach our SDG target for 2030. So welcome again. Now I would like to pass back to Margaret and Andy. Actually, these two persons are actually the most important architecture of the global health sector strategies. So thank you very much, Andy and Mac.
Thank you so much. Thank you very much, Ren, and thank you for the warm welcome to this session and to the summit as well. As Ren was saying, the World Health Assembly gave us a mandate to work with countries for the following 8 years. It's exciting because we get to report back to the Assembly, so we keep viral hepatitis visible on the Assembly agenda, and we will report back in 24, 26, 28, and 2031, where I'm sure we'll be negotiating the next strategic framework with your support. So without further ado, let me introduce Dr. Meg Doherty, who will offer some insights into this exciting tool that we will be working with you all for the coming 8 years, I'm sure. Meg, over to you.
Thank you very much. Thank you. And I hope they can pull up the slides, because we have, in the next 15 minutes, we have a very brief set of slides that we'll walk you through to give you an overview for those in the audience here may have heard some of this before, but those online, we want to make sure that we're able to share with you all the great information that you're going to find in these new global health sector strategies. Next slide, please. So we'll be covering the progress that we've made thus far towards the SDGs, a bit of setting the scene for this entire summit, what our new strategies will be focused on, some of the targets and actions, both for countries, for ministries of health, for WHO, and for partners, and the implications for countries as we move forward. Next slide. This all started, and you heard Charles Gore speaking to this in the opening, that we had our mandate really put in stone in 2016 when we had our first global health sector strategies, which set out some targets for reducing the new infections by 90% and reducing deaths by 65% for hepatitis B and C. And there was collective action to happen at country to be able to achieve this. Well, how far are we from those goals? Next slide. Well, we've had to do quite a bit of work in terms of developing the tools, the leadership, the global goods, as we call the norms and standards or our guidelines, technical support to countries, focusing on gender equity rights and stigma and discrimination that can occur, and putting out what is the value for money and the cost and cost effectiveness, which Right Honorable Helen Clark led us to believe these are best buys working on hepatitis. And now looking at the data and the data systems to measure how far we've gone. Next slide, please. So in 2021, in anticipation of developing the new strategies, we put out a report. And this report showed that overall we had 2.3 million deaths per year from HIV, hepatitis, and STI. Among that, 500,000 deaths from hepatocellular carcinoma due to these two hepatitides, and 1.2 million new cancers every year related to these three infections. Next slide. But we also put out new indications of what is the burden. When we try to look at our targets, both our impact targets of the reduction of death and the reduction of new infections, we weren't making our targets in 2021. The only target you've heard about that we've been able to make is the under 5 prevalence of less than 1%. Now that's a proxy indicator for incidence for hepatitis B, but we have to do a lot more work, as we heard, including birth dose vaccination to be able to reach our 2030 targets. Next slide, please. And this burden is enormous, as you heard, over 350 cases per year of hepatitis B and C. And what we know is we still have 3 million new cases every year and 1.1 million new people who dying from hepatitis B and C. So clearly, across the world, we see that it's variable, but also that we have a lot of work to do, and we need countries to be able to address some of those new infections and deaths as we move forward. Next slide, please. And in this report, we talked about also service delivery. And we heard this, I think, from Rwanda. Do people know their status? And unfortunately, the cascade of care shows us that still too few people know their status. 10% of the estimated people living with chronic active hepatitis B know their status. 21% of those with hepatitis C, the 58 million living right now with hepatitis C, know their status. And although that's different by regions, what we see is there's even a drop-off from testing to treatment. So even if we're starting to see a decline in our new cases and our deaths, we're not actually reaching everybody who needs to be reached yet. Next slide, please. There's been great successes, which we heard about from our colleagues from Egypt, that we've seen an increase in the DAA, or the hepatitis C treatment, where we know now we have simplified, quality assured products, and down to at least what we heard today, $40 for a cure and treatment for sustained virologic suppression for hepatitis C. But the problem is we don't have this everywhere and in every country. So we need to work on equity as we move forward with this, and efficiencies in the delivery systems. Next slide, please. And you heard this from Helen Clark, who also mentioned we don't necessarily have a good hand on how COVID-19 has impacted our services. We know at least 50% had some level of disrupted services. Could be much more, because we don't have as much data as we would like around essential health services around hepatitis around the world. Next slide. But the key is we know we have more to do, and that report gave us the starting point for our next strategies. And what you see for hepatitis, that it's in the yellow, and we'd like to be all green by the next time we have to report, that we get a positive reporting card that we're on the track for elimination for hepatitis. So next slide will really outline our new strategies. New colors, new information coming out, and I would like to say our cover here is really to show the elements of what's inside of our strategy, that we have 3 disease processes that come together to be able to reach our target. So sometimes design helps us speak to what is the goal in our strategy. Next slide. So some may ask why we need these strategies. You heard from Andy, he keeps it on the agenda. You heard from everyone earlier, we need it on the agenda for reporting, and also now for thinking about innovative financing, catalytic financing. We also know that we need to start looking towards ways of developing those sustainable systems, and much of that will be discussed over this entire summit. Next slide. So at the World Health Assembly, the strategies were noted with appreciation, but that means we have the mandate to continue to work forward. And as Andy said, we're going to continue to have the reporting, and we're going to need your support as we report forward from all of the countries here with us today. Next slide, please. If you open up our strategies, this is what you'll find: the structure and the strategic framework. So these are, in the past, from 2016 to 2021, we had 3 independent but very similar and interlinked strategies. This time around, we have one strategy that is modular, where you can pick out the work and the activities and the actions for HIV, for hepatitis, for STIs, but then across the board, there are shared commonalities between the 3 diseases, whether that be data, whether that be accountability, whether that be about integration under a UHC for delivering a person-centered approach at primary care. So we encourage you to go in and start to look at these. Go back, please. Perfect. And the only other thing I wanted to share with you here is we're also looking at 5 strategic directions, as we did last time around, across the 3 diseases. Delivery of high-quality, evidence-based, people-centered services, optimize the systems and the partnerships for impact, generate and use data to drive actions, engage and empower communities and civil society, and foster innovations. And all of that should be leading us towards ending AIDS and the epidemics of viral hepatitis and sexually transmitted infections by 2030. Next slide, please. And although I won't go into detail, this is driven, and underneath all of it is a theory of change, where if we do these actions across these 5 strategic directions, we should be able to achieve our 2030 Sustainable Development Goals. Next slide, please. What I do want to introduce you to as well, that inside this strategy, we've also looked at the counterfactual for HIV, for STI, and for hepatitis. What would happen if we don't do what we're supposed to do, if these actions can't happen, if we can't pay for them? And what you can see is we won't make our SDG targets on these trajectories, and we could, at least in STIs, we could see an increase in some of the STI that we see around the world. And to be honest, we're experiencing that right now. As public health systems are not addressing people at the center, not addressing STIs, we're starting to see a rise around the world. Next slide. We have a cascade for HIV and for STIs. I'll run right through this because we're a hepatitis meeting. But we have the costing. And all of the costing shows you put a bit in now and you'll get your gain later on, as was mentioned by Helen Clark. Next slide. For STIs as well, we need a steeper incline in our cost right now to be able to get us to a plateauing period. And for hepatitis, next slide. Oops. Seems we've missed a slide. That's okay. We have the same for hepatitis. Next slide, please. Where we will see also, if we increase our funding right now, we should have a gain over the longer term. The other element that you will need to look at when you start to interrogate these strategies is around the key targets, both the shared targets where it's across the board. Can we reduce incidence for these 3 diseases together and reduce deaths and save and have healthy lives, as well as the very specific impact indicators. And these impact indicators actually get us to about 500,000 deaths and 500,000 new infections by 2030. When you think of it, if we're going to move towards elimination, we can't be talking in the millions anymore. We need to be talking in the hundreds of thousands, tens of thousands. And that's the inspiration that we need at country level to be able to support your health systems to be able to identify all those in need of testing, treatment, and care. Next slide, please. And here we go for the counterfactual for hepatitis B and C incidence. And what you'll see on the left is hepatitis B, and hepatitis C is on the right. And the dotted line is where we would be if we don't implement our strategies. And the descending line is the kind of steps we need to take. And what our strategies have put in is a natural stopping point at 2025, or a pause, and we can see if we're on that trajectory. And if not, we can reassess and re-look at our actions to see if we need to add new actions as we move forward. Next slide, please. Here's the slide I was looking for hepatitis. So again, we have the service delivery. And I think what we heard today is simplification, simplification, access, access is what is going to get us to elimination. And we need to follow the cascade of hepatitis care like we do for HIV, so that we can actually measure outcomes for hepatitis B, for hepatitis C. And if we don't do that, we won't be able to hold ourselves accountable towards this elimination. And again, the costs may go up, but as we heard, the catalytic costs and the best buys have to be reiterated, and that's part of our strategy when you start to look at that. We've costed it for the very first time. Next slide, please. Again, these, I will walk you through these because these are so many targets and indicators. I invite you all to take these back to your ministries of health, work through them, see how you can adapt and adopt these, and work if you can adapt and adopt these targets, both on impact, service coverage, and milestones, then you'll be ready to get on the path towards elimination with us. And I think if you can put those into your M&E forms and to your M&E system as you move forward, then I think we'll be able to do this elimination work together. Next slide. Some key strategic shifts you'll find in the actions. We heard this. We need greater public awareness. People need to know their status. We also need to have access to the hepatitis B birth dose, which you heard multiple times today, and access to the testing, such as self-testing, and over the long term, curative and vaccination. So innovation could always help us, especially long-acting injectable hepatitis C and potentially cure for hepatitis B. Next slide, please. And again, these innovations will help us to accelerate. We saw so many excellent innovations happening with COVID, whether it was virtual interventions, whether it was about optimizing services. I think we need to take forward and work with industry and the private sector on these areas for actions. Next slide, please. Lastly, I'm going to use my last 2.5 minutes on implications for countries. Next slide. You'll hear during this summit a lot about these elimination pilots. WHO in June of 2021 put out interim indicators or guidance for validation of country in elimination of hepatitis B and C. And in there we have both programmatic targets as well as impact targets. The big shift you'll see in the discussion here is that we've moved from a relative reduction to trying to identify the absolute reduction. This allows us to really start to put people at the center and to allow that all countries have equal access and equal ability to get onto this path to elimination. You'll hear more detail on that, but clearly we have to increase coverage to all these services. Can't be at 40 or 50%. We need to be at 90% or higher to say that we've moved forward with elimination. Next slide, please. And these pilots, I won't spend time here, but you'll hear about them in this session. Very important, 7 countries. We digested them in detail in the pre-summit. And I think from here, we know where we need to go. Next slide. In terms of helping countries think about how to measure incidence of hepatitis C, how to start measuring mortality for hepatitis B and C, and the need for us to think about what a path to elimination might look like so that we can walk with you towards elimination. Next slide. The other thing you'll hear about while you're here is about new guidance. You heard about the Hep C self-testing. We're about to launch, and in this session, you'll hear about simplified service delivery in detail, and not forgetting our children, how we can make sure adolescents and kids in the youngest age have access to the best treatment. Next slide. And with this, I'm summing up. What are the steps on the road to 2030? We need to review the lessons learned from the elimination pilots to develop this path to eliminations. We need to begin to implement the actions and targets. There are 105 actions in this new strategy. Targets, I dare not ask, I can't remember off the top of my mind, but many targets to be able to integrate into your systems. And we are looking forward to the regional committees, regional frameworks, and pathways to be developed, updated national strategic plans along the lines of these new strategies, and building on the opportunities that have emerged from COVID-19 for the innovations. We want to simplify and really support the dissemination of new guidance and guidelines so we can work towards a test and treat approach so that we're not delaying the needed treatment. And we stand ready, as always, as WHO, to support you all, support the World Health, the WHA, the partners, and also civil society so that we can do this together. Thank you very much. Next slide. And I just say thank you to those who helped out and who've been really critical to the development of these strategies and who are now tasked with helping to implement them as well. So thank you very much. Thank you, Andy.
Thank you, Meg. I think we're handing over to Margaret now for facilitating the next part of the session. So if we could get Margaret back on screen, that would be very helpful. And thanks, Meg. For those of you who aren't aware, we do have a timer for the presenters, and Meg was almost to the second. So well done, Meg. Let me hand over to Margaret.
Thanks very much, Andy. And thanks, Meg, for a wonderful overview of the new strategies. Can I also just thank you and the WHO team, Andy and others, for the huge amount of work that went into developing these. And also thank you for everybody, many of the people who will be online or in the audience today who made a contribution to the strategy. It's now my pleasure to sort of begin to introduce our panel members. And our first speaker today is Dr. Mohammed Hassani, who is the Health Minister from Egypt, who's the Health Minister's Assistant for Projects and Public Health Initiatives. We all know that Egypt has made an enormous advances in hepatitis C elimination, and we will hear from them today, from Mohammed today, about this work. So without further ado, over to you, Mohammed.
Thank you very much, and it's a great pleasure to talk to you again and about the hepatitis elimination program in Egypt. I spoke a lot this morning and yesterday about the achievements that we did in Egypt during the past decade, starting maybe from 2006, since the establishment of the first national governing body for hepatitis, which is the National Committee for Control of Viral Hepatitis, being responsible for putting the strategies for elimination, either for diagnosis, treatment, access to service, and also the prevention and preventive measures. And following this, we have different milestones of success for the and landmarks for success in the viral hepatitis treatment program in Egypt, starting from the establishment of a very good network of viral hepatitis treatment center, well equipped with proper infrastructures and trained human power and medication that were available for different stages of liver diseases, and also the affordability of the drugs. We could achieve to contract the medications with only 1% of its global price in 2014, and then in 2016 we have another milestone for the local production of generic direct-acting antiviral drugs, which allowed us for the expansion of the treatment program and the deployment of the direct-acting antiviral therapy for all over the Egyptian governorates, and allowing us to the start of 2018 to treat more than 2 million chronic HCV patients. And at that time, I described it yesterday, that we started to face a decline of people, and all those who knew their states of infection were referred to be treated, and still we have expected from 2 to 2.5 million cases of hidden chronic HCV, and at that time we decided to do the mass screening program in Egypt, which started in 2018 and ending by mid-2019, and we discovered at that time almost 2.2 million cases of chronic HCV referred to the viral hepatitis treatment to receive the proper evaluation and the treatment with direct-acting antiviral drugs, and we almost treat about 1.6 million cases from hepatitis. Since yesterday, I spoke a lot about the achievements that we did, but also it's worthy to speak about the challenges that we face now and we expected to face later. The first thing that we should ensure the proper sustainability of the service in order to continue the achievements that we did, especially in the field of infection and prevention, and also to ensure that all the measures that ensure the continuation of the incidence reduction measures and regarding the blood safety and injection safety are all in place. And also, during the campaign, we discovered almost 250 cirrhotic patients that needs a surveillance program, and now we have nearly 70 sites for surveillance for early detection of HCC using regular assessment with ultrasonography and alpha-fetoprotein done every 4 months on the total governmental expenses, and nearly we have almost 120,000 patients enrolled in such a program. And we are trying to shift also the nature or the management cascade of HCC, as in Egypt we have a lot of centers for HCC management for liver transplantation doing resection and also the local regional therapy, and since 1 year we introduced also a panel of systemic therapy for HCC like sorafenib and regorafenib and different lines of immunotherapy to improve the survival of discovered HCC patients, being one of the most challenges that we face during that time and expected to face for many years later. And also in reference to what Meg just said about the targets of elimination, Egypt did a lot to achieve many of the targets as a programmatic or impact indicator. Regarding the programmatic indicator, we diagnosed more than 90% of chronic HCV patients. Egypt, we treat more than 90% of those eligible for treatment, and also we adopted the blood safety policy and injection safety policy to the level of the indicators of the WHO, and we expected within very few weeks to launch the first opioid substitution therapy, and we start to touch the incidence reduction, either the relative reduction, we exceeded 90% reduction of the incident cases, and also, as just Meg said, the absolute targets being defined by the WHO to be 5 per 100,000. Now we are in 2021, reached to 9 per 100,000, and we expected also to more decline during the coming period. But we should differentiate between the targets that we could achieve rapidly, as the targets that I just mentioned, and also the targets that need the time to be achieved, especially the mortality reduction. And when we started the mass screening campaign and discovered millions of cases, we expect to achieve that target of mortality reduction, but after years, maybe 3 to 5 years. Excitingly, we after a couple of years, we started to see a significant mortality reduction, reached to about 20% from the nadir level, and now we are achieving nearly 40% mortality reduction due to either chronic HCV-related liver cirrhosis or HCC, and we still need to wait for a time to achieve more to meet the WHO target indicator of elimination, which is 65%. And we expect to have still more a challenge for better management and better surveillance of those who are discovered during the campaign, for allowing also the better and also allowing better surveillance and monitoring system to ensure that all the targets are well kept at the same achievements, and we continue at the same level during the next few years until we reach the elimination targets. Thank you very much.
Inspiring to hear the work that's being done in Egypt. Congratulations again, it's just extraordinary. Our next speaker is Dr. Sandhya Kabra from India. Sandhya currently holds the portfolio of Deputy Commissioner of NVHCP and additional directors at the National CDC in India. Sandra is going to be talking today about what I think something which is incredibly important, which is leveraging the systems approach in optimising UHC for viral hepatitis elimination in India. Because as we've been told, there's not going to be, Charles Gore always puts it so nicely, there's not going to be a global fund come in and save the neglected child and provide us with funds. So we have to think about how to do it locally. So Sandhya, over to you. I look forward to hearing what you have to say.
Thank you, Margaret. Good evening, everyone. I thank the organizers for having given us this opportunity for making this presentation at the World Hepatitis Summit on behalf of India. And the topic of my talk today is leveraging the systems approach in optimizing UHC for viral hepatitis elimination in India. So keeping in line with the SDG target 3.3 to combat viral hepatitis, India rolled out the National Viral Hepatitis Control Program in July 2018 under the National Health Mission. The National Health Mission is a health systems approach where the state and the central government contribute financially through the health systems to roll out the program. India is a federal country with 36 states and union territories. If I were to show one state, then we have multiple districts in a state, which are the administrative units functional for the country. And this is focusing on one particular district where we have the secondary level healthcare structure, the district hospitals, the community health centers, the primary health centers, and below the primary health centers, the sub-centers and the health and wellness centers. In the UNC umbrella for the NVHCP and India's response to it, I have tried to color these slides to be able to showcase what was already existing and what is it that we have leveraged from by providing in the National Viral Hepatitis Control Program. So the blue piece is what we have provided in the National Viral Hepatitis Control Program, where we have done a little bit of prevention, which is basically awareness generation, injection safety, looking at blood and blood product safety. The piece that we have provided for is the diagnosis and management. We have leveraged on the existing infrastructure in terms of equipment, in terms of manpower, in terms of civil works, and we are only providing the drugs and diagnostics free of cost throughout the country. And the other piece that we have focused on heavily is capacity building. So the existing human resource has been trained and repeatedly trained again and again to provide for better capacities to roll out the program. Apart from this, the brown piece that we see is our integration with the reproductive and child health program, with the existing immunization program, with the National AIDS Control Program, with safety of blood and blood products through the blood transfusion services in the country, and surveillance programs across the country. We have pitched in various surveillance programs, which I'll be coming to later. So keeping in mind the universal health coverage, we are ensuring access across the country with focus on priority groups by identifying appropriate interventions, by addressing quality through standardized trainings and quality commodities, by ensuring financing through integrated approach, avoiding duplication and domestic funding, 100% domestic funding for sustainability. Next slide, please. So our integration with the existing reproductive and child health program is clearly documented here. The piece on green is what is our existing infrastructure, which is provided by the healthcare systems. So we have the primary healthcare and we have our referral health centers. The reproductive and child health program already offers for pregnant women the provision of free referral services from a primary to a higher level facility. The mobilization, the transport costs are already covered under the Reproductive and Child Health Program. We are providing with hepatitis B surface antigen screening kits, building capacities, and screening all antenatal mothers for hepatitis B. We are further providing linkages with the National Viral Hepatitis Control Program for management of pregnant women, ensuring that these deliveries are referred to a higher healthcare facilities where there is a provision for the 0 dose of the hepatitis B vaccine and hepatitis B immunoglobulin to babies born to positive mothers, and ensuring safety to the healthcare workers while conducting these deliveries. The birth dose vaccination is being provided through the immunization program, which has been existing since 2011. And now we have included provision of hepatitis B immunoglobulin to those born to the positive mothers. Integration with the existing AIDS control program. Again, the piece in blue is what we provide, which is screening kits, vaccine, and capacity building. We focus on the testing and treatment sites under the AIDS control program in the form of integrated counseling and testing centers and the ART centers. After having this screening, anyone found to be positive for hepatitis B or C is linked to the National Viral Hepatitis Control Program for further management. Again, we are also interfacing with the high-risk groups in our targeted intervention sites, including the opioid substitution therapy centers under the AIDS control program, and leveraging on the harm reduction activities under the AIDS control program. We are also, through the health systems, providing for sample collection, camp-based approach, or fixed day visit of clients at health center so that they can be screened and they can access services. And also, all those in the targeted intervention sites who are screened negative for hepatitis B are being offered the hepatitis B vaccination. Integration with other existing national programs. We are integrating with the surveillance of viral hepatitis at various levels. We are also integrating with the population level surveys and programs like the National Family Health Survey and the HIV Sentinel surveillance to estimate disease burden and to reach up and measure the SDG indicator for financial efficiencies. We are also interfacing with the population-based National Family Health Survey. We are leveraging on the existing surveillance programs for control of outbreaks of hepatitis A and E, as ours is an all-comprehensive viral hepatitis program, and cancer registries for surveillance of hepatocellular carcinoma. In India, blood is regulated through an act of the parliament, ensuring 100% screening of all blood units for hepatitis B and C, apart from the other TTIs. And India is also moving towards attaining 100% voluntary donation in the near future. We also established linkage of screened positive for hepatitis B and C in existing blood transfusion services and dialysis program with the National Viral Hepatitis Control Program for further management. Thank you very much. This is a consolidated effort. This is our political leadership, our administrative leadership, our state teams, my own small team at the Viral Hepatitis Management Unit. I thank WHO for their support and all my state nodal officers present in this picture who are part of the health systems supporting the program moving towards elimination. Thank you very much.
Thank you so much, Sandhya, for that really great presentation around an integrated approach, which I think is really important for us to understand that this is possible and how we will achieve this. It's my pleasure now to introduce our next speaker, Mr. Ibrahim Abdullahi. Today, Ibrahim is a special advisor to the governor of Nasarawa State in Nigeria, and he will be talking to us about modelling domestic resources for viral hepatitis in the Nasarawa State in Nigeria. So thank you very much, Ibrahim. I'm not currently hearing Ibrahim. Is anybody else?
Thank you very much for having us. It's a real pleasure to be here. I'd like to start by thanking the organizers of the World Hepatitis Summit for giving us the platform to share the Nasarawa story. I bring you greetings from His Excellency, the Governor of Nasarawa State, Engineer Abdullahi Sule, whom really wanted to be in Geneva with you physically, but due to state emergencies, is unable to be in Geneva and even attend virtually. So I am here to represent him, and it's a great pleasure. I think it's interesting to state that for us in Nasarawa State, before our hepatitis elimination program, we really even were not alarmed. We were not aware of the gravity of the disease because no one was talking about it. We didn't have the data. We were not alarmed. But in 2019, when we came into office as a new administration, in partnership with the Clinton Health Access Initiative, we got access. We had access to the data, and we got the situation analysis. And at that point, we appreciated the gravity of the situation. Nasarawa State has the highest prevalence rate at about 14%. That is higher than the national average. It then began to sink into us as government that we needed to do something and something immediately. And that was what gave the impetus for us to start the Nasarawa Hepatitis Elimination Program with the support of the Clinton Health Access Initiative. And it is also interesting to state that before this intervention with our elimination program, we were really looking at this disease with less political attention and response from policymakers at the highest level of government. And in view of other also competing government priorities, and most importantly, the high prevalence rates in the state, we decided to approach it from an economic lens. We came up with the Nasarawa Economic Development Strategy that has a very ambitious plan to make Nasarawa State one of the top 3 most competitive states in the country. And it was very clear in our minds that with this high prevalence rate of hepatitis, it was clearly an impediment to our human capital development aspirations, and we needed to tackle it from that lens. So that really made us increase the awareness, bring it to the front burner, and put it as a critical part of our health sector strategy. That made us to come up with this robust elimination plan with financing, service delivery, and partnerships at the heart of the strategy. We set up a technical working group to support government efforts. At the highest level, we signed this elimination plan. The governor himself signed the elimination plan, a 5-year elimination plan. Before this 5-year elimination plan, we were not testing and we're not really treating. But with this elimination plan, we've created a framework that ensures that we test and we also treat. This has also given us the opportunity to have a conversation with pharmaceutical companies around the supply chain to support our robust elimination plan. We have never seen this kind of support, this kind of political will on tackling a disease like hepatitis, because it was never even in the front burner. But thankfully now, with this elimination plan, it is at the heart of government's agenda. It's at the heart of our health sector strategy. This has brought an opportunity for us to continue something robust and something sustainable. And it is important to state that our 5-year elimination plan seeks to screen about 2.4 million people within this 5 years and treat over 100,000 patients, all within this plan. We cannot do it alone. We think that government political will is important and essential, but we need all hands on deck. We need all of the partnerships on the table to make sure that we scale this elimination program and also replicate this in other parts of the country where they have similar prevalence rates, and also even across the African continent, because I think that we're doing something phenomenal with our partnership with both the Clinton Health Access Initiative and pharmaceutical companies, local communities, traditional rulers, and other key political actors. Thank you very much.
Thanks, Ibrahim. That was... Sorry, I'm just trying to stop my timer. You were beautifully on time. Thank you so much for a really interesting and important sort of presentation. I'll just put it in the minds for people for the panel discussion. You, on a number of occasions, talked about the importance of political will then being translated into community action. Really interesting to hear that. So thank you. Our next presenter is John Ward. I feel like John probably needs no introduction, as many of us know John, who is previously at CDC, but now at the Coalition for Global Hepatitis Elimination, the Task Force for Global Health. John's been working in the sector for many years and will be today sort of really highlighting what innovations are needed to reach hepatitis C elimination. So thank you very much, John.
It's great to be. Can you hear me? It's great to be halfway in person, and that's great to be able to share and exchange ideas with the audience around the world. I was asked to touch on some different aspects of innovation that, some of that was introduced by Meg as she went over the global strategy, as that is one of the key elements of it, innovations for impact. And it really got me thinking about why do we seek innovations in disease elimination? And there's really two purposes. One, to improve the shortcomings of our current strategies and technologies. And secondly, to respond to emerging issues as we progress toward elimination goals. For me, I sort of broke this down into three areas. Number one, we definitely need innovations in our current strategies and technologies. First and foremost, we need improvements in testing, given how many people are unaware of their status and not in care. That brings to mind a test, point-of-care test to identify current HCV infection so we can have a true test and cure strategy for hepatitis C. It brings to mind improvements in point-of-care testing for HBsAg, improvements in cost and quality, and also indicators of the women at highest risk of mother-to-child transmission. That also brings to mind the need for multiplex platforms so we can have a more reliable options for testing for triple elimination strategies for HIV, syphilis, and hepatitis B. When we think about treatment, I think we really need some better algorithms and technologies to simplify staging of HBV disease and decisions regarding treatment and the monitoring of that treatment. And then obviously the big focus is looking for better treatment options, the functional cure for hepatitis B. And really always keeping in mind that really needs to be amenable to a public health approach to really have broad-scale impact rather than just remaining in the domain of specialists. When I think of hepatitis C, there's still some key populations that have unanswered questions, such as what is the safety of HCV medications for pregnant women? There's other options, as Meg touched on, such as long-acting therapies for hepatitis C that could greatly expand options for delivery of hepatitis C to prevent transmission as well as to interrupt disease progression. And then there's still a need for a hepatitis C vaccine for the highly vulnerable populations for people who inject drugs. Secondly, we want to capitalize on the innovations that are coming out of the pandemic response to COVID-19, as well as other health initiatives. It was great to see increased attention to those opportunities in the final strategy. One area that the strategy touched on that I thought was really important was the better use of digital technologies that could greatly help us with our public health data around hepatitis, which is really often of poor quality and really challenges us to validate progress and monitor and evaluate program performance. And we have some new options in that regard. Secondly, we also have some new options of making prevention, testing, and treatment available to individuals, patient-centered care, telemedicine, other uses of communications. And then with expanded communication options, we have better availability of channels to engage communities, educate those communities, and mobilize responses to hepatitis. And then there's also options to improve harm reduction, such as drug treatment for persons who inject drugs other than opioids. I'm also very interested in the social network approaches, which are very effective for HIV and even contact tracing for COVID-19. And what are the lessons learned from that, and how can that be applied to our work of scaling up prevention, testing, and treatment? And then thirdly, what strategies could make the current interventions we have available more available? I mean, hepatitis elimination is feasible because we have effective interventions now. So what do we need to do? I think, we need to simplify models of care for hepatitis B, a grossly undertreated population that needs to be rectified with operational research. We talk about integrating hepatitis D testing and treatment. How are we going to do that in systems already challenged to take care of hepatitis B? I'm very interested in what are the operational research questions to scale up hepatitis B birth dose in Africa, particularly for home births. What are our options there? And I think we need to continue to look for strategies to provide services for the displaced, the incarcerated, the distantly located, and the stigmatized populations. I think they always have to be in front of our mind of how we can improve hepatitis prevention for them. It was great to hear India really provide some details about integration. I think we really need to strengthen the evidence base there so we can move from integration of hepatitis into HIV, primary care, and other settings, move that from aspirational goals to a set of tools that can be replicable and tailored as needed to reach those populations. And then, as we touched on, we need better financial models to build capacity for hepatitis elimination. We have a number of options, but we have yet to find that secret sauce that really engages a broader array of funders, and that's one of the challenges we have. I'm sure all of you have other ideas for what's a priority. It can be a very long list. But I think when we think about innovation, I like to think that we always want to keep the affected communities in mind, keep them engaged of what priorities we're coming up with, to know that they're shared by those communities, and so that the innovations are well received once developed. That we keep the ultimate goal of disease elimination first and foremost in our minds, and that's health equity. Innovations need to be broadly available. And then lastly, be open to sharing what you're doing. That's one of the functions of our coalition. One standard operating procedure for one program is an innovation for another program, and I think it's very important for us to continue to function as a community of practice dedicated to a shared goal of eliminating hepatitis. I look forward to learning about these and other innovations in the coming days. Thank you.
Note there is this combination of how do we simplify things? And to me, I think it's really important, that ongoing discussion with the community about how we keep things simple. Maybe the good is better than the perfect, to be able to make things available, and in hepatitis B, that ongoing discussion about care and treatment and access, perhaps treatment for all. Our final panel member and speaker today is Rachel Halford from the Community Hepatitis C Trust. Rachel's worked in the sector for very, very many years, and she will be talking today about viral hepatitis and the global community. I think it's just critically important that the community plays a central role in this. I think the new strategies identify that, but Rachel, really interested in what you've got to say.
Thank you very much. Oh, can you hear me? Yeah. I just need to check this because I've actually got some slides. No, I think I'll have to say next slide. I don't know how to work this. I'm really bad with gadgets, sorry. I just want to say thank you very much. I am delighted to be here today to talk about what I think is truly putting people at the centre of rights-based health and how important a role civil society, people with lived experience of hepatitis have in supporting the global goal to elimination. We all know that elimination will not happen in silos in traditional health systems. We need to be creative, decentralise services and deliver integrated, patient-centred approaches. And civil society sits at the centre of this. So in my next 5 minutes, I want to share with you the impact of having the right things in place. When a country has people, policy, finance, medication and information in place and truly puts in a meaningful way people with lived experience in the centre as a key stakeholder delivering services. Next slide, please. So here we have the hepatitis. I'm going to tell you about the Hepatitis C Trust, and I didn't know Charles was going to talk a bit about it today, so quick reminder here. We were founded by 4 patients, one of them being Charles, initially to raise awareness, educate the public, and lobby and advocate for policy change around hepatitis C. Today, we have a staff team of 115 paid workers and 120 volunteers. More than 90% of these people have lived experience of hepatitis C, substance misuse and or criminal justice. And as a part of the go back one please. And as a part of the UK elimination drive, we deliver peer support programs across local communities and the national prison estates. And just to give you a little example, background of the UK landscape, we are a high-income country. We have open access to treatment for everyone. England has multiple case-finding initiatives funded under an elimination deal. Policy in prisons is in place requiring all people to be offered testing as they enter prison. And the Hepatitis C Trust, so our peer programme, is centrally funded and we are a key stakeholder within the NHS in England elimination programme. Next slide, please. So we all know that with hepatitis C, and this is relative to hepatitis B as well in terms of civil society being at the centre, but my focus is on hepatitis C today. So we know with hepatitis C, many of the people affected are people who inject drugs. They're marginalised and often sit outside healthcare systems. As such, they're not hard to reach because we know where they are, the majority of them, but they can be and they are very hard to engage. Peers, people with lived experience, are a solution to this. So peers, how they do this is through identification. We all know when we identify with somebody, kind of our shoulders go down, we breathe, we can hear, we listen. So peers are able to address and reduce stigma and encourage the hardest to engage to access testing and then support them along the treatment pathway. Really briefly, our peer programme works in many different ways. We deliver group workshops where a peer will tell their life story, weaving in Hep C messages and harm reduction, really important that. We deliver one-to-one support. including support down the treatment pathway, so literally following somebody, picking them up. We complete testing, DBS testing, civil society patients can deliver testing, Cepheid machines. We train frontline staff, really important that we deliver that frontline message around hepatitis C awareness. We also produce materials. Really important is that none of this happens in silos. We work in partnership. This is all about partnership, and I think we'll hear it all over the next few days. So partnership with other professionals is key to the success of the peer programme. And there's just a few examples there of different areas we work. Next slide, please. Just the outcomes, which is a bit really that tells the success of the programme. So just a snapshot from April 21 to March 22. 32,277 people accessed were reached through hepatitis awareness workshops. So that's through a peer telling their life story. Just in 1 year, this is 19,919 people were tested through community outreach. So that's on a van, someone with a rucksack on their back, someone walking down the road. So that's just our peers testing people. 3,759 were supported with hepatitis C. Of them, 2,560 have accessed treatment. And just to add it in, just under 11,000 people, professionals, attended our training. Next slide, please. I just want to hone it down a little bit. So we have an elimination programme in England, which started in July 2019. So since July 2019, peers, so people with lived experience who are paid, and the volunteers, have supported 9,040 people through treatment. Some of them, you'll see also, just to kind of draw your attention, this is not just the first treatment. For some people, it's a second treatment too. And you'll see the increase there that's kind of in the year 3, the increase in retreatment, which is concerning, but it's not to talk about now, so we'll come back to that another time later, I'm sure. Swiftly moving on, next slide, please. Our prison peer programme, we talked about this. We deliver the peer programme in prisons as well. Just to draw your attention, because I know I don't have much time, just down to the bottom graph, which is clinics and one-to-one, including hits. So I just want to explain this a little bit. We've got one-to-one contacts, so that's contacts going out on a wing, on a landing in a prison, in liver clinics, but also in whole prison testing events. 46,639 people have been reached in that period of time, bearing in mind that COVID actually restricted us for a year where we couldn't access prisons. 33,601 were tested. Of them, 30,244 were tested in whole prison testing events. This is an initiative that we run, and we work in partnership with the prisons, with healthcare providers, and the peers. We deliver this program. We go into prisons, and we can be there for a day or 2 weeks, and we test every single person in the prison. And what that enables us to do, because we've got the testing as people go in, is we're able to announce micro-elimination within some prisons. To date, we have 20 prisons that have achieved and maintained micro-elimination. And really, this is about civil society being in the centre and delivering with all the other key stakeholders. So finally, next slide, please. If we are to truly eliminate hepatitis C and leave no one behind, we really have to listen to and include the people affected. And you'll be hearing over the next 3 days, there will be many sessions that you can tap into hearing from community across the globe. There's some amazing activities that are happening. And if you don't know your community organisations in your countries, please go and find them, because working with them, some incredible results can happen. So we need to listen to and include people affected, the people with lived experience, decentralised services, organise services around people, and take treatment and testing out into local communities if we really want to leave no one behind. Thank you. I got carried away there.
Andy?
Yes.
I'm not sure, because the session started late, how long we've got before we have to stop this and go on to the next part of the session. So can you give me some guidance, please?
Margaret, we are under some time pressure. And so what I'd like to suggest is super rapid feedback from each of the panelists, plus Meg, plus Ren, on what they've heard that's most inspired them today from this session, 30 seconds. And then sadly, we will have to close. So I know people have been putting questions into the chat. As Rachel said just now, we have many more sessions coming built into this summit. So we have further opportunities to answer those questions. And certainly we as a WHO team, if any of those questions are directed to us, and I suspect as well for the Hepatitis Alliance, we will be happy to take them offline. So Margaret, with your permission, I think that's the way forward.
Just add one thing. Yeah, I think that sounds great. Can I just ask that our panel members, in your 30 seconds, give us just the one thing. If you could only have one thing as well, like what did you learn, but what would be the one thing you'd do?
Fantastic, Margaret. Thank you so much. And what I suggest I do, so we give our last panelists some time to speak, and I'll put my colleagues on the spot. I will turn first to Meg. For your 30 seconds, we heard some fantastic examples, very different contributions from the panelists, which was great. So congratulations on who was involved in selecting this panel. It was brilliant in its diversity. Meg, what was your inspiration or take home?
Laid out. So the India program told me exactly how they're addressing integration. So I took that as something we need to put into our implementation tools.
Fantastic. Fantastic, Meg. Thank you so much. Dr. Ren, can I come to you next?
Probably the same observation as Matt just indicated very clearly. It's integration, because in hand culture we're talking about a lot of integration across different disease programs, but clearly we don't have an answer. Even we were approached by our colleagues in system strengthening and primary health care in terms of integration. We don't position ourselves well to respond. What's exactly integration? So clearly it's a very interesting practice in India. So it'd be great to know how that integration means and how is that integration kind of guidance from WHO to the different country, different contexts. Thank you.
Thank you. Thank you so much, Ren. Dr. Hassani, you always inspire us with Egypt's leadership, but I'm sure you've also heard some ideas today. What would you like to share?
Yeah, thank you very much, Andy. It's an inspiring session, and it's very important to hear from each other at different levels. We heard a lot of experience from different countries. And finally, we do not have one-size-fits-all. There is no standard model to be applied in different countries. And I think we still need to leverage our efforts to reach the process. We put the targets of 2030 elimination, and now we are, the WHO continued the efforts to hear from different countries their model of care and how could they progress towards elimination. This is a very good thing to help each other, the strengths and weakness of every different healthcare system, and how to improve this to reach the elimination target. Thank you.
Thank you so much. I'm looking at the order that our panelists spoke, so I wonder if we can join Dr. Sandhya now from India. You've heard some praise for your presentation. Hopefully we can connect with you now again virtually to hear your 30 seconds of what you've heard from others today. Dr. Sandhya.
Yeah, thank you, Andy. We would probably like to learn a little bit more on the infection prevention control and the safe injection practices, because that is a huge challenge for us. And we are struggling. We have issued instructions that, reuse prevention syringes should be used, but we are still struggling with a lot of informal sector existing in the country for healthcare. So that is something that, we would like maybe to learn from Egypt or other countries who are doing this well.
Thank you so much. Can I now turn to Dr. Abdullahi from Nigeria? Same question to you. Thank you.
Well, thank you very much. I think what has come out very critically on this session is the need for increased awareness, for more synergy and partnerships, and also increased funding to ensure that all of our elimination aspirations are achieved in a sustainable way. Thank you.
Fantastic. This is a great way of getting a summary of the session, actually. I'll use this again. Really, really thoughtful reflections. Thank you. John.
Just great to what? Okay. It's great to see the diversity of countries involved in hepatitis elimination and how their commitment and passion and creativity is being applied to develop effective programs. It always truly inspires me when I hear this and have an opportunity to work with them. Secondly, again, I think it really, I think reaffirms the role of the coalition in providing a forum to share those lessons learned, so those kinds of experiences get out on the table. Having a research agenda that really helps people put together programs more effectively, as I try to touch on a few of those key items, key areas. And then lastly, just redouble our commitment for capacity building so that these programs can get adequately supported and more countries can develop effective programs.
Thank you so much, John. Rachel?
I guess in terms of what we've heard, I think the integration in India, again, same as everybody said, was amazing. But I guess my comment on the end would be, please don't forget about the community. I know we have to have the systems in place, but by working with the community, with civil society, we spark off each other. It's a joint thing, whether it's about testing, whether it's about, there's a link all the way through this. There is a link, probably not with the funding because we're not rich, the community, because we're not funded particularly well. But I guess the other thing would be, the funding, really important. That's core too. But the testing and just don't forget civil society. Don't forget about your community organisations. Don't forget the patient. This is, incredible that we have this opportunity to fight and eliminate a disease, but there's a person sat under that. There is a human being, so don't forget the person underneath it all, please.
Rachel, I think that was the perfect point to end on. So I would like to thank Margaret for being a fantastic co-moderator, and a thanks again to all of the speakers for this session. We will now change quickly to a follow-on session, so I'll invite our colleagues who are currently, I think, have other commitments. Megan and Ren, please do vacate the stage, and we will move swiftly on. Thank you.
And good afternoon, everybody. I recognize that we now have 40 minutes for the second half of this session. And my name is Fumi Leshi. I'm the team lead for viral hepatitis in the Department of HIV, Hepatitis, and STI. And we will jump into this second session without further ado. So I shall hand over to Nicholas, who is my co-moderator, to introduce himself and to help us get started. Over to you, Nicholas.
Okay, thank you. Thank you, Fumi. And hello again, everyone in the room and online to the World Hepatitis Summit. I'm Niklas Luhmann. I work in the Global Hepatitis Program. And welcome you to this session where we will focus on our framework of validation for viral hepatitis elimination and the piloting exercise that we did. I just wanted to, I'll hold it up, there are some prints out here. I just thought this morning in the opening session there was a lot of talk on viral hepatitis B and C are really this infectious disease that can be eliminated. And amazingly, we have published the first global framework for the criteria that will allow us to validate this elimination. And because that was a very important document, we piloted this criteria with 7 countries. And we learned an incredible amount of lessons from this piloting. And many of those countries are here today to speak shortly. And so we will hear from Fumi in presentation format what are the main lessons learned from this piloting and exercise of this important framework, and then move to hear a little bit from the countries as well. So, Dr. Lesi, over to you. You introduced yourself already, and we hope to hear from the lessons learned from our exercise.
Thank you very much, Nicholas. I will try to make this presentation in 10 minutes. So I'll be very brief and I'll be swift. Now, I am pleased to present this report on behalf of the pilot team in the 7 countries, the WHO regional offices and the country offices, and here at HQ, and some of our partners that were very important and critical in countries, including US CDC and Clinton Health Access Initiative, especially in Rwanda. we appreciate all the countries that participated in the pilot, especially for sharing their valuable data. And this data helped us to shape our learning experience, both for the countries and for WHO. It was clear that it was not a validation exercise, but a learning exercise. Next slide, please. So this report is a summation of the findings of the pilots from all of these 7 countries. Next slide. Okay, I think I have the control. Okay, so this framework, which we all know so well about, is the result of 2 global consultations that took place in 2021 and was attended by over 50 global experts and Ministry of Health representatives from 15 countries. The work was supported by 3 background papers that used the literature reviews and modeling to suggest the validation options and criteria, as well as a survey of country preparedness for validation that was done in 28 countries distributed throughout the WHO region. One important thing in this slide, the principles that will guide the implementation of these criteria include the aim of being country-led, applicable to different countries and contexts, and implemented efficiently using pre-existing health systems if possible. And of course, we must mention promoting human rights and equity in access. Again, this is a slide we're all very familiar with. On the left is a reminder always of the definition of viral hepatitis elimination. Reduction in incidence and mortality by 90% and 65% respectively from the 2015 baseline. So one of the key shifts in this criteria is the use of absolute targets to describe these impacts. And this is for several reasons, including to enable direct comparison across countries. Now, this particular slide shows the incidence and the mortality targets of hepatitis B and C in relative terms in the first row and the absolute terms in the second row. Just to clarify that the hepatitis B incidence is captured by the prevalence of surface antigen in children 5 years or less in recognition of the predominant mode of transmission from mother to child or in early childhood. As shown on the right side, 80% reduction in HCV incidence translates to an annual incidence of less than 5 per 100,000, and also for people who inject drugs, it's shown there. Before I leave this slide, I want to highlight that the criteria includes attaining 1, the impact targets, 2, the programmatic targets, and also documenting the implementation considerations. Again here, in the second half of this table shows the program targets. And we know that the EPI, the expanded program for immunization, has been strong for viral hepatitis. So we have the criteria in countries that have birth dose and countries without birth dose. Looking at some of the testing and treatment and prevention, some of those programs have been pre-existing, including the blood transfusion services. And what is really new in terms of programming is the testing and the treatment of viral hepatitis. Again, to mention, we now have, I like these words, option A, option B, option C, and option D. So countries are free to decide how they want to approach elimination. And we encourage elimination of both B and C, but countries, in terms of their strengths and limitations, can choose one option first as a step to elimination. So the country pilots, very quickly, they were developed to assess the feasibility of the criteria that I just described with the following objectives. 6 countries in low and middle-income countries were invited to participate, 1 from every region. We also included the UK, England in UK was invited so that we could explore some of the validation countries questions, such as how do we estimate HCV incidence, as well as, very importantly, facilitate comparison of available program data against existing modeling work. So some of the methods we used include desk reviews, key informant interviews, virtual, hybrid consultations, and importantly, we have standardized WHO hepatitis B and C protocols and tools. Data was shared by Ministry of Health, like I said before, as a learning process, and there were expected outcomes for both the countries and WHO. Of course, we appreciate that there must be some limitations to this work, including the selection of the countries and their unique characteristics, which may not be quite applicable to all the member states. Very quickly, again, I will go through the findings. The findings allowed us to develop country profiles based on the data shared by the country. And the data was not validated or reviewed for quality, but the systems were evaluated for measuring the desired outcomes. And these are examples of the country results, and a copy of this report is in the hallway for all of us to take a look at them in greater detail. So I'll quickly jump to some of the key lessons that we have learned. And when you look at this table, it's a table of the consolidated results from countries, and this in particular is for the PMTCT. So the dark blue colors in this framework, or in this traffic light, not quite traffic, but blue traffic light, shows the countries that have the relevant measurement systems in place in dark blue. And the lightest blue shows the countries that do not have the measurement systems in place. In the mid blue, the systems were available with some limitations. So quickly going through the table on the first half looks at the impact target, and it is noted that 5 of the pilot countries had done serosurveys at some point or the other to assess the prevalence in children under 5. This was done in Rwanda as part of the HIV impact assessment survey, and in Georgia it was done with the COVID-19 survey. At the time of our review, Thailand and Rwanda and Georgia are already reaching the impact target for this indicator among children under 5. If we look at the lower half of the table, there's a lot of navy blue in here. And these are the programs. And this is evidence of strong PMTCT, strong immunization, vaccination programs. And very quickly, 2 things we have learned from PMTCT. This assessment using national serosurvey is feasible, but costly, and may require some flexibility for measurement in older children. Just to quickly talk about some of the findings we found in the UK. The mother-to-child transmission was an additional target for countries that provided targeted birth dose, as in England. And from their data, the estimates from routinely available data, sorry, my connection went off, show that they were able to assess the prevalence and the MTCT rates at less than 0.1% and less than 0.2% respectively. So this helped us to reach the decision that expansion and strengthening of routinely available monitoring data and evaluation can provide empirical data for the assessment of both hepatitis B incidence and MTCT rates. So the same color coding, but this is a different color, where the dark color shows system availability is shown for hepatitis C incidence. And you would see on the first row that there's only one country that had the WHO preferred measurement, and that country was Egypt. On the other hand, for the alternative measurements, there were 2 countries, Georgia and England, that had that. Some of the key lessons for us were that direct measurement of HCV incidence using country-level evidence is feasible and requires resources and political commitment. Now, the viremic prevalence is a very important metric, and some of our colleagues online from Georgia and England will possibly give us some further information. So the decline in this prevalence may not be a satisfactory proxy for direct measurement of reduction of transmission in all settings and populations, but absolutely it's a valuable additional metric for measuring progress towards elimination. One quick point on routine case registries that was seen in countries like Brazil, and surveillance of acute infection failed to adequately measure HCV incidence. 3 more quick lessons for HCV. The use of absolute impact targets for measuring progress and validation is definitely going to be a challenge in high-burden countries. And the table on the right actually shows several high-burden countries and where hepatitis C is more concentrated in these LMICs. One particular cascade mechanism, the estimated number of people diagnosed among those living with chronic HCV in the population was often underestimated. That is an important point because of the common use of cumulative numerator and a recent point denominator. I think we know that the patient pool of HCV infection shrinks as patients are treated and cured. Therefore, defining a denominator from 2015 or closest to that may be a more realistic assessment of this metric. And in terms of prevention, safe injections and NSP programs remain challenging. In terms of hepatitis B and C specific mortality, here I'll go super quickly. The vital registrations had limitations, and the differential mortality rates for B and C may differ from global and country level. The key lessons, number 4, the validation criteria, tools, and processes were very well received by the countries. The tools were considered quite robust and acceptable. However, they need to be further refined. And of course, there's a need to establish global and regional governance for commencing validation. I just put this here as an example of what the feedback tool looked like. The countries were asked to give us feedback on this criteria. In summary, we have 5 priority considerations from the pilot. The first is WHO definitely needs to establish a set of criteria for path to elimination for the validation of hepatitis B and C elimination for high-burden countries. This is interesting because if we look at the hepatitis HIV, PMTCT, they used programmatic data to define 3 tiers of progress from gold, from bronze and silver and gold. So there are questions for HCV and HBV elimination. Should this be program targets or should we include impact targets? Do we need 3 tiers or do we need 2? So another consultation will possibly be required to establish that type of path to elimination. The need for governance process is clear that has the appropriate expertise and manpower for viral hepatitis, as the multi-disease elimination is not quite ready to be delivered to the countries. Alternative measurements and methodologies for B and C need to be explored. Importantly, as in number 4, the use of program data alongside mathematical modeling to determine attainment of these targets require to be further explored. And of course, we need to develop a more specific and detailed guidance and tools, fine-tune the tools to support country pre-assessment and data collections. I would like a long list of acknowledgements for all of the people who supported this work, from the countries to WHO regional office and to the partners. And I want to say thank you very much for listening.
Thank you so much, Phumni, for this interesting presentation. you know, in some way it might seem quite technical, but I think we learned that even though with some limitations, those criteria where we were able to see from the countries that in some countries at least all of those criteria were able to demonstrate, and that we saw as well with the 7 countries that extreme progress has been made, and that in some of those countries it seems really quite close to being able to achieve all of most of those targets. So that was really one thing that very practically came out from this work. And then I think, why do countries have to know about that? So there are those countries who made huge progress, and I think with them we found out where the last gaps are, and we will work with them on those last gaps. And for the other countries who are maybe a little bit, so to speak, behind or starting, or I think they have a framework to see where they need to go to, and so that they can work with all of us and all together to really start that path to elimination as well. So you want to...
Yeah, actually, you know, Nicholas, thank you. I think one of the important reasons is that countries need to be able to measure their own progress and tell the community and the people that we have moved from one step of achievement to a second step. Again, I think WHO needs to celebrate and to recognize countries who have reached elimination, and like it's done in polio, where they get an award for recognition, this is the tool towards accomplishment and towards being publicly recognized for elimination. So I guess it's important to all of us. The meaning of this tool is real. It has life application. The tool may be technical, but the meaning talks to the hearts of people. Thank you.
Absolutely.
Okay.
Exactly. You're so right. So I think that's why as well we want to hear from our 7 countries that actually provided a lot of their time and contributed a lot of work. And so we have 3 of them on the panel here. Yeah. And I will just, we will do a rapid fire, a little bit like in the session before. Mm-hmm. So unfortunately, we have other sessions coming up. We'll give you around a minute to just comment on one question. And thank you again to have engaged with us on all of that work. The question that we wanted to put to all of you is, what is unique to your hepatitis program that would inspire and motivate other countries for elimination? So really about the uniqueness of your program and what is inspirational for others on that. I'll start with Dr. Ana Cristina because she's next to me. She's from Brazil and joined us since yesterday, and you have about 1 minute only.
Thank you, and good afternoon, everybody. I think that what we have the unique is our unified health system that is have universal access, and it's distributed all over the country in the more than 5,000 municipalities. So this permits to us to be everywhere. And also the program has like a very sustained of supplies. We have like central procurement, and this enables us to guarantee for the population all this. And also we have like robust national systems that we have some challenges in linkage the data, but we are in this way. So I think like with these 3 things, we have great potential towards elimination, and this is like something that may be unique. So thanks.
Thanks, Dr. Ana Cristina. Actually, engaging with Brazil was very amazing. Always a lot of people exchanging with us. And you're right, it's a real health systems approach to infectious disease response, I think, since a long time that you can build on. Thanks for that. It's quite a good, unique point. I'll go over, or hand it over to you, to our colleague, if we can have the microphone, from Thailand, Dr. Jamsiri, with the same question about what's unique and what can inspire others in the Thai hepatitis response. Thanks.
what's unique about our government and our health system is that we have a very strong immunization program. We start our hepatitis B program since 1988, and we scale up nationwide, and our vaccine coverage for hepatitis B birth dose reached 99% and maintained for about 20 years. And for the third dose of hepatitis B, it's also maintained more than 95% for now. So that's one of our strengths. Another strength is that we have very strong primary health care, which work under universal health coverage. We develop a program to make sure that we can implement our hepatitis B prevention comprehensively. So we develop our Hep B EMTCT program, which implement now in 46 provinces from 77 provinces. And we also conduct a zero prevalence survey for hepatitis B, and we found that our children aged less than 5 years already reached 0.1% prevalence, which is very near to our elimination target. So we hope that we be one of the countries that be able to reach the triple elimination goal next year.
Thank you, Dr. Jasmiri. I think it is.
Recognize that she said they are thinking of option A next year, and we are really excited to be working with them for option A. I think we should give them a round of applause. That's a declaration so that we can follow up.
You're so right. I think we have to say for those online who might not, or even here who might not know, Thailand, as she said, has been validated and maintained for HIV and syphilis transmission from mother to child. And we hope to continue to engage with you to bring in hepatitis B and look into option A with you and the Thai government and our partners in Thailand. Definitely deserves a round of applause. Now the last country in the room that engaged with us, and we've heard already from Dr. Hassani today, so quite a lot, but over to you, Dr. Hassani. Anything you want to highlight? It has been already very inspiring for others, but maybe we want to just hear how you answer that question as well in 1 minute. Thanks.
Thank you very much, Nicholas. And I think what is unique in the Egyptian program of National Hepatitis Elimination Program is the two factors strongly interconnected. The presence of huge infrastructures allowed us for the local production of medicines, which enables us to go for the robust step of mass screening. And the mass screening program went in a rapid pace. We finished almost 60 million in 7 months, and this is break the chain of the introduction of new infections. In Egypt, we expected every year to have additional from 100 to 150,000 new infections of hepatitis C. And these steps allowed us for breaking this chain of new infections and allowed us to rapidly discover people and link them to care. Thank you.
Thank you very much. Very, very good point about the local production. And just to say again, because you said this morning, I've seen through this pilot that you have made huge reduction already in mortality and incidence as well, as you were able to share with us and document. And that deserves a round of applause as well, because those are the impact targets that we're all trying to meet. So I'll hand back to you, Phumni, for more applause, I guess, and more country examples that are online.
Yes, thank you very much. We have 3 collaborators online from Mongolia, from England, from Thailand. But one of the first things I want to say, from the workshop yesterday, this report was beautifully received by the participants, and one participant made a comment that oftentimes they hear elimination from researchers or from partners, that this is the first time that they're hearing elimination from the ministries of health. So I think one of the unique selling points of this report is this is insider information from the countries that are participating in the pilot and also the governments of those countries. So it's really exciting for us. So I don't know who is on the call. Is Dr. Janvier from Rwanda on the call? And if you're on the call, the question is, what is unique to your national hepatitis program that will inspire and motivate other countries for elimination? Dr. Janvier, thank you, and over to you. You have 1 minute, or 1 minute 30 seconds. Am I correct? Okay, over to you, Dr. Janvier.
Good afternoon. Thank you very much for the floor. I can develop many points, but let me develop one strong point. What I can say about Rwanda political will, because the political will is for all the doors to be open, and it's a will to advance all the initiatives that are taken. So the political will brings the commitment, it brings the awareness at all levels, awareness for the population, for the stakeholders, partners, and so on. So it brings all the partners on board for the partnership, especially for the financial support and so on, but as well for the technical support. So I may say it helps us to make free all hepatitis services. So that's the political will. So testing and treatment was free so that the population in need can access easily those services. Another point maybe is the task shifting and decentralization. So we trained massively our healthcare providers across the country in all health facilities, and the hepatitis management activities were shifted from doctors to nurses, and then it helped us to decentralize all those activities to the lower health facility levels. So briefly, those are the two main points, but the strong one is the political will. Thank you very much. Over.
You know, I think you're right. The political will is the elephant in the room, really, very important, because it creates an enabling environment and gets things started. Thank you. I'm going to call on Dr. Mazaya from Mongolia. If she's on the call, would you please, can we see your camera if you're on the call? And if you're okay, Dr. Mazaya?
So I want to mention that the point of the hepatitis elimination program is healthy liver program in Mongolia, which is very the largest, which had the largest funding in the one in health programs implemented by the government of Mongolia during the last 4 years. Also, currently, Mongolia has a well-established health system with integrated screening and testing care services at the primary care level to health insurance. It means the health insurance database functions very well to facilitate insurance reimbursement and provides important data per program. Also, Mongolia has a strong immunization system, and as well as the very high coverage. And also, the Mongolia is aiming for an ambitious goal of the option D, the elimination of viral hepatitis B and C, in addition to the AMTCT. That's all. Thank you very much.
I'm actually still in shock. Thank you very much. Let's give her a round of applause. And do you know what option D means? Option D means A plus B plus C. That is awesome. Let's give him another round of applause. Fantastic. Thank you. So we'll follow up, and we look forward to working together to reach that goal. I have seen on the screen Dr. Monica Desai from UK, from England. Thank you very much for joining. Monica, you have the floor. And the question is, what is unique to your hepatitis program? We know what is unique, but you tell us what is unique.
Thank you, Fumi, and good afternoon, everyone. So Rachel and Charles have already given some examples of the initiatives we have, so I'm actually going to focus on our data. Just as a bit of background, England has relatively low generalised prevalence of hepatitis B and C. Our epidemics are quite concentrated. So focusing on the data, I suppose there are a couple of key unique features. The first is that we primarily use routinely collected monitoring and surveillance data, supplemented by surveys in high-risk populations to monitor our progress towards elimination for both impact and programmatic metrics. Our key survey is an annual biobehavioural survey amongst people who inject drugs. It's been running for 30 years, and so that provides a rich source of temporal data. But this reliance on monitoring and surveillance data means that the systems that we use to evidence are embedded in our health systems, and we focus on strengthening those so they're representative. We can monitor trends in a feasible and sustainable way. The other point is that we have the legal regulations to collect patient identifiable data on hepatitis. So it means that we can link our data, which means that we can map a care continuum from risk to diagnosis, testing, treatment and outcome, including disease and death across multiple health data sets. And so that allows us to identify where there are gaps for targeted interventions. But we do recognise that standalone surveillance monitoring systems do have their limitations, coverage, data quality issues, biases. So we triangulate a number of data sources using mathematical modelling approaches. And we feel that that provides us with a much better understanding of the data, greater confidence in our estimates of incidence, and use that to identify gaps in the care cascade and direct interventions, policy, funding, particularly to areas of inequality of access and health. And within that, we also triangulate laboratory sequencing that's been key to identifying outbreaks and transmission networks. And I guess the final point to make for us is that we, as Fumi mentioned, have predominantly looked at changes in serial prevalence and also incidence side by side using modelling approaches. And we've seen a decline in chronic prevalence, largely due to treatment effect, but our measures of incidence haven't really seen a decline yet, possibly because of historic underinvestment in harm reduction, possibly still because we're a bit too early to see a treatment as prevention effect, and also possibly a contribution of reinfections. So for the England epidemic, we feel that incidence alone doesn't provide the full picture, and we are keen to continue looking at both serial prevalence and incidence side by side. And I suppose a question to WHO whether both could be accepted to give us a better overall picture of what's happening with our epidemic. Thank you.
Thank you. Thank you very much, Monica. It's great to see the work being done with empirical data and modeling. As we round up this session, I'm looking at the time, we have 5 minutes. We are grateful to the government and the Ministry of Health of the 7 countries and their willingness to share data. And in some instances, the data was incomplete, but they allowed us to use the data. So we appreciate them. They allowed us to use this so we can learn, and they too can learn what is necessary for validation. Just to summarize what we've heard today, the uniqueness of the programs we have heard today support elimination. We're looking at data, vaccines, systems, political will, decentralization, very key to elimination. So I think on behalf of the piloting countries, we say a huge thank you. We really ought to have a few questions, but I don't think that we have the time for questions. And I would ask everyone to maybe type their questions in the chat, and then we can come back to them with responses. So right now, I'll introduce my colleague, Dr. Philippa Easterbrook, and invite her to give a short talk on the upcoming guidance and guidelines from WHO for viral hepatitis. Thank you very much. Philippa, over to you.
Thank you. Hello, good afternoon. I'm going to go very fast. If I could have the first slide up and the next slide. So this is a super quick preview of the upcoming updated hepatitis C guidance, which will be launched at the EASL conference in London on the 24th. And there are three main new areas that we're updating: simplified service delivery, decentralization, integration, and task shifting. Hep C diagnostics, that's the point of care technologies for viral load and reflex viral load testing, and treatment of adolescents and children. And what we have is an overall updated guideline. And then there are going to be two policy briefs, one on the simplified service delivery and the Hep C diagnostics, and the other on treatment in children and adolescents. Next slide. So I think we've heard a lot about measuring elimination and the path to elimination, but what is absolutely key is how we're going to get there. And if we're going to achieve the 90% testing coverage, the 2030 target, and the 80% coverage of those diagnosed treated by 2030, we are going to need a substantial scale up in testing and treatment beyond what we know we have to date as of 2019, which was around 20% who'd been tested and overall 13% treated. So next slide. So fortunately, being in the Department of HIV, Hepatitis and STIs, we have the opportunity to learn from each other and build on what we've learned from the HIV response. And so the evolution of the HIV guidelines was from progressive simplification of treatment, starting treatment earlier, and then adopting the service delivery simplifications of decentralization, first in 2013, so initiating ART and maintaining at peripheral health facilities, the task shifting sharing to non-specialists as well as non-physicians who are trained, as well as nurses, both initiating and maintaining. And most recently in 2021, much more work on the service integration. Next slide. So we followed a similar evolution, but much faster, much more compressed, with the Hep C guidelines from 2014, 16, 18, and now 2022. So to the treat-all approach in 2018, the dropping the genotyping because we had pan-genotypic regimens, reducing the number of regimens to now 3 preferred regimens, the SOFVEL, the SOFDAC, and the GP. And now what we have in these new guidance is expanding it to include the adolescents and the children and the simplified service delivery, as well as the new diagnostics. Next slide. So, quickly to summarize those main headline recommendations, the decentralization, making a strong recommendation for testing and treatment at lower level peripheral health facilities, moving the care out of the specialty centers, the tertiary facilities, and also into the community. And ideally, testing and treatment at the same site. And this could be primary care, harm reduction, HIV clinics, prison settings, as well as in the community, and also recommending integration of the testing and treatment into other existing services, be it harm reduction, primary care, in the HIV centres, and finally on the task shifting to the trained non-specialist physicians and to the nurses. Strong recommendations. The moderate quality of evidence was largely with the persons who inject drugs and the prisoners. General population, we still have a little less data. Next slide. And the overall message as we approached our WHO guidelines is strong evidence from a very large study of 142 studies, systematic review, comparing full decentralization, testing and treatment at the same site, where testing is then delivered at one site, referred for treatment elsewhere. That's partial decentralization or no decentralization, a specialty center. And there was increased uptake of viral load testing, linkage to care and treatment, where there was full decentralization. And when we compared specialist versus non-specialist and nurses, we had comparable outcomes in task sharing. So a very important message. And this was supported by our end user surveys, of which we had 3, confirming strong support for having decentralized and integrated services near to their care. Next slide. Second group of recommendations, point of care viral load. We already had a recommendation for using a lab-based NAT assay for diagnosis, and now a recommendation on the use of the point of care or near point of care technologies for both diagnosis and test of cure. And another innovation and initiative was a recommendation for reflex viral load testing, a very simple phenomenon whereby anybody, if they have a lab-based HCV antibody that's positive, the lab immediately reflexes to do a viral load test. Very efficient. Or if it's in a clinic setting and you have a positive rapid diagnostic test, there's an immediate sample collection to test then for the viral load, either in the lab or a point of care. Next slide. So again, strong data to support this, 2 systematic reviews showing both these initiatives, improved outcomes with the point of care, reduce the turnaround time, increase the uptake of viral load, increased uptake of treatment. And clearly these are benefits that can be applied at lower level facilities. And now with these point-of-care platforms that were available for HIV, TB, and now COVID, it provides a framework for us to have access to existing facilities. Next slide. And then the third group is really the extension to the treatment in children and adolescents. And I think we're all familiar with pediatric HIV, the children being left behind for so long. So now just really in 5 to 6 years, we now have a recommendation, which is for treat all down to the age of 3 years. So including in this guideline, all adolescents, all older children, all younger children down to 3 years, and using the same regimens that are recommended in adults. So provides that procurement and supply chain efficiency. A little less data in the younger children. Next slide. So clearly the strong evidence is really to treat the children and adolescents before their disease progresses, and to really aim for a hepatitis C-free generation. And good evidence from this systematic review of high efficacy above 95% across all regimens for the adolescents and the older children. Very few adverse effects, very few discontinuations. We have these drugs approved by regulatory authorities already. And for the younger children, we don't have direct evidence of SOFDAC in these younger children, but we did have data from some modeling which suggested we could use the same adult dose in the children down to 25 kilograms and a half dose down to 14 kilograms and even 10 kilograms. So we now have the tools to be able to scale up. Next slide. So just as more take-home messages, things to reflect on, and we, in our pre-summit, we had some discussion on these issues. The implementation considerations for countries are really going to be adaptation of these service delivery models for their settings and populations, and really the planning processes to ensure we've got integrated data systems and cross-training of health providers, task sharing, obviously the training and the ongoing mentorship is going to be key. And next slide, and I think final slide. And then on the point of care assays, countries will need to think strategically of the right mix of the laboratory-based NAT assays, working with the strategic placement at the point of care. That could be in settings, harm reduction sites where the volume of testing may be low, but they don't have lab capacity, hard to reach populations. And I think a really important message is that one-stop shop. If you can have the point of care platform at a site where you're doing testing and treatment. That is the boutique and the ultimate service delivery model for promoting access, uptake, and complete linkage. And the multi-disease platforms are obviously a real opportunity going forward. Reflex testing is being widely done in terms of lab reflex testing already in high-income countries. The protocols, the SOPs exist for that. And then for the clinic-based as well, this is being widely done, but it needs to be systematized a little more in those settings to make the process efficient. So that's the rapid fire. I think that is my last slide, and just my acknowledgements on the very last slide to the members of the Guidelines Development Group, and of course to the many WHO colleagues and country partners. Thank you.
Thank you very much, Philippa. There's a lot in the pipeline, and we are looking forward to the full launch of these products at EASL in the next 3 weeks. Thank you very much. Nicholas, over to you. We're going to invite Andy to give us closing, but okay. Okay, go ahead.
Okay, for the housekeeping, we're sorry we're a little bit over. The next session is lightning talks on and abstracts on advocacy, awareness, and education efforts. And for those who are in Geneva, you can join in Kofi Annan room here. It will be streamed here, and for the others, it will be online. And then there will be a parallel session after that as well, streamed in the room here, that will be announced after the lightning talk. That was the housekeeping. Andy, can you please close us out? Thanks.
For sure. So I guess my job is to, in less than a minute, just say a few words on behalf of Dr. Renmin and Dr. Meg Doherty. And talking to them earlier, they really wanted to recognise a number of the themes that have come out of today already. First of all, congratulations to everybody who's taking part. This has been a fantastic start to the summit. And a number of themes have come through which will continue. I think we've heard partnership and collaboration, lesson sharing, all of the themes that are happening in the context of this summit, frankly, are critical. It's a highly dynamic space with highly dynamic actors. So this is exciting stuff. It's fast moving, but you're listening to each other and you're getting together and you're learning from each other. You're learning from different contexts, and really, it's just a shout out to all of that sharing, which has been very generous today. Recognizing a couple of the themes that came out this afternoon around political will, visibility, keeping viral hepatitis on the agenda. All part of our work in WHO, and all part of our broader work as a bunch of as stakeholders around this agenda. So I'll keep it at that. Thank you, everybody, for really constructive and thoughtful engagement, and let's keep that energy moving into the other sessions.